Yeah, you'll be fine if it's like less
Yeah,
than
because
20
they all
for
say
sure.
96 and above. Well, I don't even know how.
Okay, guys, we are recording.
Oh, thank you.
And then I think grab this.
Becky, I have a gift for you.
Oh, perfect. Thank you. Okay. Guys, we're just filling out attendance forms, so I need you to check your course keys. And if there are any errors, I need you to fill out an attendance form for me so that we get those fixed, please. And we're going to get started here. All right. So the plan for today, we're going to do our Module 7 Pediatrics unit. Okay. And then we'll take a little break, and then we're going to come back and we're just going to do a review of the content we're studying actually today so that we can be ready for the CMS, okay? And if we run over, I'll continue back with you into your half-an-hour break. It's not required. I'm just offering it as a benefit because some of the content could very well be on the CMS. I wanted to give you an extra need to jump in all that information. What?
Do you have time at some point before the end of next week to do 2 remediations?
Uh-huh.
Because I was trying to set up a time and no.
Okay, so when you went on to the website, it doesn't show any time available.
Uh-huh.
Okay, I'll double check that, and then if one of those times does not, we'll find a time.
Okay, I'll just meet with you at some point.
Okay, come see me after class, and we'll figure out a time that will work for me.
Like, I think I have one other one and then today's.
Okay.
Yeah.
Okay, that should be great. All right, I think I have that with you.
Okay. Is Nick here?
He's not coming.
He's coming from the test.
Yeah.
All right, so today at 3:30 we have our CMS exam. That remediation is due next Tuesday. Oh, okay. Remember that the remediation on the exam is different than it is for the practice, right? This one, it's based on your score and it's based off of your lowest ALT. Mm-hmm. So just remember the difference. Remember, if you get a 1 or below, you do need to meet with the coach, okay? Like always, I say get on 2 days. If you get a less than level 1, you want to be scheduling that like right away. That's, I think, the hardest part about remediation is getting in touch with national coaches, okay? So make sure that you find a time that works for you in your schedule by scheduling that early, okay? And then don't miss them. Remediation is required to take the remediation, okay? And that's in full, right? All 4 components of that have to be done, okay? And then our final is next Wednesday, the 25th at 8 a.m. That is also the day that we have our final simulation, our final lab day. And you guys will have your meetings with the ACEN accreditors that day as well. So it will be a busy day on campus. It's probably the day to bring some easy to eat snacks or something that doesn't need to be heated up because there won't be a lot of time to do that sort of thing in between those hours. Okay. And then Friday, after your med search final, will be the CMS retake day. Okay, if you need to retake both of them, you'll have to retake both of them on that Friday. There won't be any time on Wednesday. Although the other option would be, technically you could take it 5 days from today, so you could take the pediatric one on Monday after the doctor gets there. I still like that a lot.
That would be a lot.
So I felt like Friday was a better day, but it's
Friday for what?
the P3 retake, potentially, because you have to wait 5 days between. I don't know. I just don't feel like that's a good idea, but it is a possibility.
Oh, it's just counting days. No.
Yeah. Okay. All right. Remember that as we go through things that I'm pretty sure, doesn't mean the other stuff won't be on the end, like the things that we know we've seen repeated on the end have 3 marks, right? And things that are just like for you guys to review at home, but I'm not going to go into a ton of detail in the class. Okay. So today we're going to finish up with cardiac disorders, hematology disorders, and then we're going to talk about death and dying in the pediatric population. Okay. We're in the Walter Spur book in chapter 34 and 37, and then pediatric API books 19 and 20. And then we've pretty much covered both of them. You believe it? Okay, interesting. So we've got quite a few objectives today. Make sure you review those, especially if you're studying for your chapter test next week. So let's start out with congenital heart failure. Somebody tell me what that means. What does congenital mean? Yeah, you're born with it, right? Something you're born with. Well, that's congenital heart disease. So what I want to say is that pediatric congestive heart failure is just like adult heart failure, but it usually happens in the presence of a congenital heart defect. Okay, so we do actually have quite a few babies in our population who suffer from congestive heart failure. So what do you think it would look like to your baby versus an adult? What would be the difference? You guys understand congenital heart failure pretty well.
Can they like grow out of it?
They can. What do you think? Tell me what it looks like in an adult, and let's see if we can figure out what that looks like in a pediatric patient.
Like swelling.
So they have edema. So where's the edema in an adult? Okay, and why is that? Why do we get edema in the feet?
Circulation.
Decreased circulation, but where does water go? Down. Okay, so we're upright most of the time, right? So what about a baby? On their back. So where do we see edema in babies usually? Is it on their feet? No. Do they get puffy ankles? Like the nose? Where do they get that? Where do we see it? On their stomach? A lot of times it's in their face. And a lot of times we actually see it. It's easy to see like around their eyes. We call it periorbital. Okay. So around the face, their eyes get swollen. Sometimes even their little ears can get swollen. Okay. But mostly, if we're in the early stages of heart failure, the first thing we usually see is they just don't eat well. Remember, with our little guys, eating is their job.
Yeah.
Right? That's what they work all day to eat. It takes all the energy they have, and sometimes more energy than they're consuming just to eat. Right? So think about poor feeding failure to thrive kids. They may sweat while they're eating. They may get diaphoretic. Okay? They may be tachypneic. Okay, so we're looking for, we have to remember what their job is. And you know, a farmer with CHF wouldn't be able to go out and plow his field. And so we see that as evidenced by how well they're doing with the feed. So that's what we want to make parents aware of. Now, if they're a little bit older in the pediatric population, then we'll see that they maybe aren't wanting to go out and play with their friends, or they don't tolerate getting to and from their classes if they're a high school student, or and their edema is going to resemble more adult edema. Okay? Now, they both, no matter whether they're old, young, almost always have tachypnea. Okay, their lungs are still wet. So what do they sound like? Oh, exactly. And then they're all going to have some type of weight. But water retention? Yeah, it's that edema, right? That fluid retention. But what's the guideline we use in adults for weight gain for fluid? How much can they gain before we're worried?
Like a pound a day.
A couple pounds, right? Like, we're not gonna freak out about 1 pound, but if we see a pound every day for a week, we would freak out. But you can't use that same thing with a 7-pound baby. So what do we use as a guideline?
A pound per day.
It's too much for
Ah,
a baby.
So we're talking about adults could gain like maybe a pound per day, but over a week, if you have like a 7-pound weight gain, is that a problem if you're an adult?
Mhm.
Is it 1 pound per week?
2 pounds per week?
How many pounds a day?
It's gonna be based on their size. Okay, if I have a NICU baby who only weighs 2 kilograms, okay, if I see like a 10% weight gain, I'm concerned. Yeah. Okay, so 10% would be 200 grams. Okay, but if I have a 15-kilogram 3-year-old, what would 10% be? 15 pounds or 15 kilos.
1.5
thousand, yeah, 1.5 kilograms.
Okay, so a couple pounds. So can you see where like 10% in a baby is a couple grams, like maybe a couple ounces, right? Maybe 10 ounces. But in a 2-year-old, 3-year-old, 4-year-old, that would 15 kilos, if I used a 10% rule, it would still be like 2 pounds. That's too much for a kid that size. Okay, so the bigger we get, the smaller percentages are acceptable to gain. Okay, is that okay with you guys? So you're gonna have to gauge based on the age and the weight of the child, what is an appropriate amount. And usually if you're inpatient or acute or even outpatient, there will be a plan in place. If they gain more than X number of pounds, then we're gonna like start diet. Okay. Other causes though, rheumatic fever, cardiomyopathy, severe anemia, and Kawasaki disease. Okay, all can cause congestive heart failure. Like we said, that fluid, weight gain, exercise intolerance, edema, failure to thrive, okay? Decreased fast. All right, in terms of NCLEX, think difficulty feeding, okay? Know that when we have rheumatic fever, we're gonna talk about that a little bit later, but if we have proper rest while we're in that phase of rheumatic fever, we won't do as much damage to the heart, okay? So if that comes up as a question on the NCLEX about what your nursing care should be, it should be stay at rest. Yeah. And then we always check that apical pulse, just like in adults, before we administer digoxin to babies, and we hope that baby's heart rate slow. Now, is it the cutoff going to be 60? No, because remember we start chest compressions at 60 on the baby, right? What would a cutoff be maybe for a newborn? What's the normal low heart rate for a newborn? 120, 120. Yeah, again, the doctor's probably gonna give us an order for that, okay? Because there's not like, they're not kind of one size fits all. But it's gonna be on that lower end of normal, okay? So if the lower end of normal for a child is 80 to 100, just know that in that 80 to 100 range, we're gonna be good. So it's age-based. And that's the thing that gets you with PEDS, right? If it's a PEDS question, make sure you know how old they are, right? And what the normals are for that age. Yes, don't get caught up in that. Don't get caught up in that. Okay. In terms of nursing care, guys, you so much education needs to be done with these parents, okay? They're gonna need to get a baby scale because they're gonna need to weigh their baby every day. Daily weights are still the same, okay? And so there's some extra equipment they might need. Chances are those babies are going home on monitors, right? We're gonna monitor their oxygenation and things like that at home if we can, and oftentimes they're on oxygen. Feeding and medicating safely, so small frequent meals, just like with adults, okay? So lots of things cross over. And then making sure they understand how to get those medications. And then we need to prepare families for a lot of testing. Okay, and with pediatric patients, those always seem a little more traumatic than if your spouse or your mom needs to have them done, right? Same procedures, but it's a little bit scarier for them. All right, we do classify it, let's see, into stages. This just kind of gives you an idea, but if we're just like stage 1 or stage A, our ventricular size is still normal and they're asymptomatic all the way to stage 4 or stage C, where we're in a lot of trouble. Okay, so you can kind of see how this goes and what we would do down here. I'll let you guys look at that at home. There's also a link to a really, really good article if you feel like some light reading over the weekend. Yeah, I say that. So. Okay, all right, so let's go back, let's backtrack and see what in the heck causes that congestive heart failure. I just wanted to do that one first so you knew where we were headed with a lot of these. So again, structural abnormalities, they're present at birth, okay, and we classify them into 2 categories. There's cyanotic and acyanotic. Which of these babies are blue? Cyanotic. Yeah, exactly. So these are lesions or abnormalities, okay, that cause babies to not be pink, okay? And the more stressed they are, the less pink they are, typically, okay? So the biggest one, what's that? Did you do your pre-stuff? Did you talk about petrology of below and all that? You guys had some pre-work on that. What do you guys remember from those? The cyanotic heart lesions. The 2 biggies, petrology of flow and transposition of the great vessel or the great part. What do you remember what they were?
The transposition of the great arteries, tricuspid, and then what do we say? Cardiac.
Okay,
The trumpet.
there's truncus arteriosus, so there's
Yeah.
5. You can go with the 5 if you want, but the biggies are the transposition and then the those are more okay. A lot of times now we're so good at ultrasounds. It's not like it was even 20 years ago when we may not have see that. If you're having a good ultrasound, like a skilled tech at a, not just a, I should be careful when I say this, but a lot of people have an ultrasound, but it's not a true anatomy scan. It's not a skilled ultrasound tech that knows what they're looking at. Usually, if you've had a proper ultrasound done at, between 20 and 24 weeks, they can just these things up. And knowing before the baby's born allows us to do what? What benefit is that these exist?
The conditions that they'll have.
Okay, yeah.
Emergency things on the end.
Yeah, where are you gonna deliver this baby? Are you gonna deliver this baby in Stampede? Nope. Where are you gonna deliver a baby with these cyanotic heart lesions? In Utah, there's really only one place in Provo. Primary. You don't deliver at primary children's here, but you deliver at the U, and then we have a big crosswalk that goes right over to primary children's. Because that's where most of our pediatric cardiovascular.
Doctors?
Yeah, you would be referred to maternal fetal medicine and give these all a very close. So our acyanotic heart lesions, these are like your atrial septal defects, ventral septal defects, right? Your PDAs. These, the coarcts need surgery oftentimes right after birth, but a lot of times the DSDs and ASDs, they don't. A lot of times they just close on their own and can be washed. Same thing with the PDAs, okay? But your cyanotic heart lesions, for sure, need to be delivered at a higher level of care. Also, it's helpful for moms to wrap their heads around it, right? Before the baby's born, they know what to expect. Maybe they can get involved in a support group or something like that. So it is really helpful for them to have a heads up. Okay. It's also not helpful for what we're being on Reddit. So maybe discourage, I don't know, right? The internet's awesome, and at the same time, it can be difficult. I don't know. Technology's changed things a little bit, but so the biggest thing is that, well, let's go back to risk factors. So whatever interferes with that cardiovascular. So think way back, like 16 weeks ago, when we were talking about fetal development in our mom baby class. When does the heart develop? Let me ask you this way: when can you see a heartbeat? When can I see a heartbeat? We can hear it externally by the beat, right?
Yeah.
By about week 7, for sure, possibly sooner. Okay? How many people know they're pregnant at 7 weeks when the heart is fully formed and developed? 5%. Yeah, I don't know what the number is, but it's not very high. So when we talk about teratogens, okay, meaning substances that mom has been exposed to or ingested that cause these things, how many people even know to avoid certain meds, alcohol, drugs, tobacco, smoke, or exposure to heavy metals? At least 50%. I mean, there's lots of people who, as soon as they know they're pregnant, can talk these things, but they may not have known they were pregnant.
So would it be good teaching that if you're sexually active just to automatically take pregnancy tests, or if you're like drinking and stuff?
I mean, I think if you're not protecting yourself from pregnancy, but I don't,
Then birth control's not always effective, so.
I know. I don't know that
But
there's a
you
good
should-
answer to this.
should-
I'm just making the point that most women don't realize they're pregnant by the time this has already happened.
Interesting.
Okay? That doesn't mean we're gonna be like dishing out ounces of guilt or anything, but it's just something to be aware of. Also, what do we know about rubella?
It's live.
Yeah. Okay, what vaccine is this in? What vaccine are we
MMR.
doing? Right. And we're gonna check, right? We're gonna see, are they rubella immune or non-immune? Because if they're non-immune, we wanna make sure that they don't have another pregnancy where they go without that, right? So we're gonna give them that vaccination after they deliver, okay? We don't give it to them while they're. Okay, so in terms of diagnosing them, we're gonna look, on echocardiograms, X-rays, MRIs, and look for, those structural abnormalities. We look at the EKG, we're looking for arrhythmias, and then the tetralogy flow, it has the most characteristic, cardiac silhouette out there. Like, you see this and you know, that boot is classic. That's not what it's supposed to look like, okay? That boot-shaped heart. But just, a lot of times too, we're looking at the fetal echoes, while mom's still pregnant, okay? So if we look at the acyanotic ones, we're talking about a left to right shunt. Okay, that means blood from the left side of the heart crosses over to the right. So what that does is it overloads our pulmonary system. Okay, it maybe gives us pulmonary congestion. But it means that oxygenated blood goes back to the left side of the heart and goes back to get reoxygenated. That's why they're acyanotic, because we're mixing oxygenated blood to unoxygenated blood. So it's a very ineffective system, but it's not going to cause cyanosis, okay? Here you can see this is the hole between the ventricles. Here's the hole between the atrium, okay? This is the ductus that didn't close off when the baby was born and took their first breath like it's supposed to. And then this is, can you imagine the big aortic arch? And then there's this little tiny spot right there, okay? Do you see why this one requires surgery, okay? Because they've got to fix that. Now, if this is persistent, it can cause issues, but we will give it some time to close up the bone and see if it'll do that, okay?
Question,
Yes,
for the one that will give it time, if it doesn't, then will they do surgery for it?
yeah, we do PDA ligations all the time. So we go in, we put a little clip, like a little. And a lot of those, we just do on the unit.
Will they then, after the surgery, like, be able to live a normal lifestyle, or will they have to be restricted from like sports?
Once it's closed, it's closed. Yeah, so unless it's occurring with another lesion, it's okay. Okay, so we talked about the signs and symptoms, diagnosis, either, in utero, again, echoes and heart cath. Treatment-wise, we're talking about potentially surgery, but oftentimes just waiting out on its own, or we're doing meds, okay? If we're managing care, we're obviously listening, right? We're listening to those heart and lung sounds, monitoring that. We're looking at weights, we're looking at pulses, okay? All of these conditions cause unequal blood pressures. Remember how we did 4 extremity blood pressures on babies when they're born? Part of what we're trying to pick up for some of these abnormalities, okay? Making sure their pulses, both brachial and femoral, are equal, okay? And then the EKGs. Lots of family teaching. We've got to teach them. They're usually on special formula, okay? Very susceptible to infection, so lots of good hand washing, just basic stuff there, okay? And then, what am I thinking on that last one? funny that I'm having a total blank. I don't even know what I meant. Poor weight gain, poor oral intake, infection reduction, self-feeding. Okay. All right. Questions on that one? I think I covered all that. Listening. Okay. And the video that this is a summary of is right here. You guys can click on that link. I really don't have time to watch them all. They're only about 6 or 7 minutes each. They're really well done. I would recommend you guys go listen to them. Okay, here's the cyanotic one. So this is right to left. So in these lesions, the blood is crossing from the right side of the heart where it's unoxygenated over to the left side, and then it's going out to the body. So essentially what's happening is we're having blood that sheds that's unoxygenated. It mixes with oxygenated blood. So the blood coming from the heart isn't fully oxygenated, right? If we have a 20% mix, well, then our stats are still going to be low, right? So this is why they're considered cyanotic lesions. These babies are blue. We tolerate sometimes really low oxygen saturations in these kids we take them to surgery. I mean, sometimes in the 70s is where their normal is until surgery. Okay, because it's mixing, it can't get any higher than that. You can't take 100 and mix it with the unoxygenated blood and have anything higher than that. Okay. So just know that these kids oftentimes they do need oxygen, lots of medications, surgery to fix it. Okay, here's your 5 T's to do. Okay, let's see. I'm just checking my notes here. Know that surgery is dependent on the type of defect that it is. Okay, so these kids are fine. I just want to say this. They're fine while baby is still in utero, right? Because who's doing all the oxygenation? Mom. Okay. Oftentimes, we'll put them, one of the special medications we put them on it is called a prostaglandin. That is to keep their ducts open. So you know how in a cyanotic lesion we're actually wanting that to close. With these kids, that's oftentimes their lifeline. And they will look and they'll look totally normal until that duct is closed, and then they'll crash. Because once that duct is closed, that's when the defect becomes apparent. So we'll sometimes start medication to keep it open intentionally until we're ready for surgery. So we talked about that all babies have to have congenital heart defect screening, CHD testing, before they go home. It's a requirement. We usually don't do it before 24 hours. And that's where we're going to put that monitor, right? We put it on the right wrist, which is a predistal limb, and then the other one goes on either leg or the other arm. And we're monitoring for very sometimes small differences between those two numbers. Okay, we have computerized equipment now. Once we put those on to analyze it, we don't have to do it ourselves anymore. But we're trying to pick up on that very subtle change. Babies who have some of these defects, they can go undetected, sometimes for a week or more, and then these were babies that suffered like from sudden cardiac arrest and died. And so we knew that by screening everybody, we would save a significant amount of death. So we actually are treating more CHD babies now that we do that screening than we ever have before, because they just look fine and normal. Maybe have a murmur, but we weren't too worried about it, and they go home and then they would die. So it's CHD testing has it's made it, we have a lot more patients in the program, and we've saved a lot of babies. Okay. All right. So if we have a CHD baby, when do we call our provider? Things that would be alarming to us, right? Decreased oxygenation, if they're breathing fast, they're really retractions. We see increased cyanosis, they start running, all those signs of distress. Okay. We watch them pretty close. If we send them home, right, we're going to teach the parents that they need to bring their baby and bring those things as well. Okay. There's a bunch of slides in here I hid for this discussion, but I'll turn them on and send it out to you guys after and you can see them all, just as you're studying. But there's too much to cover. So just remember, acyanotic left to right, that's the important part. And we end up with pulmonary congestion. Cyanotic is right to left, okay, and we have decreased oxygenation. You can remember that, you should be good. That is the big take home for these okay? If you know more, awesome, that's great. But I think the biggest thing is understanding which way they shut. Again, signs for congestive heart failure. So in terms of nursing care, we're clustering care. Okay, these aren't kids that we're getting in and bugging all the time. We protect them, right? We don't let, labs come and poke them whenever it's convenient for them. We've really got to protect their rest time. We maintain that oxygen. We do not want them to cry. Like, we'll do anything to keep them from expending that energy. Oftentimes, if they cry, they just go blue, blue, blue. We call them, have you ever heard of TET spells? Like a baby with tetralogy, well, if they start crying, they'll have like a TET spell where they just are really blue and can't oxygenate at all. And when you get older kids, we have a good friend who had this little tetralogy little baby, and as he got older, like he would have those TET spells, like he'd be like 2 years old, and if he got upset, like he'd just have to do that, tripod breathing, and I mean, they're a real thing. It was crazy. He's a little miracle though. I think he's had like 5 open heart surgeries or something like that to correct it. But okay, lots of emotional support. And then here, right, left to right, think congestive heart failure symptoms. Okay, but the cyanosis one, the cyanotic lesions, the right to left, they're the ones they're going to have. Sometimes they're even born with clubbing. Right? Because but if not, they'll have it pretty quickly because they definitely don't try enough that to prevent that. So they'll do that squatting. Here's a video for you to go back and watch on rheumatic fever. Who knows what rheumatic fever is caused by? We're going to watch that one. Anyone? What is it? Yeah, strep. So this is the one where, like, if we don't treat strep throat, this is what can happen. Babies or mom or anybody. Anyone. But we see it mostly in children, like ages 6 to like 5. Okay. So in rheumatic fever, what happens is you end up with a strep infection, okay, and then your body has an immune response to that, usually because it's treated properly. Okay, and you go into this acute rheumatic fever phase, and there's this. We use what we call the Jones criteria. Okay, so think joint, and then I don't know. Carditis is what it stands for. They get these nodules. They get this really crazy rash that's very characteristic. And then symptoms create are basically like these involuntary movements, almost like Parkinsonians if they were like an adult. Things like that. Okay. They usually have a fever, elevated bed rate, and usually a prolonged PR interval. So these kids can be pretty sick. They need to be on bed rest. Okay. Difficult to keep kids on bed rest, but if they stay down, we can obviously limit the amount of cardiac involvement. Okay, so if we get somebody who's in an acute rheumatic fever episode, they need rest. Okay, what happens is it turns into rheumatic heart disease. So the actual fevering portion actually settles in and it causes problems with the leaflet in their valves. So right now, in terms of like our cardiac population, because think back like when our 60, 70, 80, 90-year-olds were young, this occurred a lot more often than it does now. Okay, I think most parents are pretty good about recognizing stress here, but what about other countries? Do you think they still see a lot more of this than we're seeing in the U.S.? Yeah. So again, antibiotics usually are penicillin. We will give aspirin in rheumatic fever. Okay, it's the one exception. We'll give it here, and we'll also give it in like Kawasaki disease. And then bed rest. Okay. Then if they get rheumatic fever and they have rheumatic heart disease, they have to be on long-term antibiotics. Okay. So think about like if you go to the dentist or hospitals. Okay. Also, their dental care becomes super critical. All of these heart diseases need really, really effective dental care. So what does that mean if you're 3 months old?
Your gums.
Yeah, it means we teach the parents how to very effectively clean their gums every time they feed them. Okay? things you wouldn't normally think about, have to become like things that are very struggle with. So, okay. All right, Kawasaki disease. Who's heard of this one?
I've heard of it.
Yeah. You what?
Heard of it.
You've heard of it. So we have some really good friends who had a baby with Kawasaki disease, and she has had her original heart, and she's had 3 heart transplants. So this is one of the biggest reasons for our pediatric heart transplant with Kawasaki disease. So essentially, it's a vasculitis, and it affects the arteries, mostly usually those cardiac arteries, and so they end up needing a heart transplant. Those severe cases do. Anyhow, she was 2 when she was diagnosed, and got her first heart transplant at 2. That one lasted her about 8 years. She got her second one when she was 10. That transplant, though, when you're on ECMO and you're waiting, you take what you get, and it wasn't the best match. She never did really super well with that second heart. It was her 3rd heart, but her second transplant. And so it only lasted a couple of years, and then they weren't sure they could even do another one because it's not super common to have a 3rd heart transplant. And can you imagine, you have to trim off so much of all those vessels every time you disconnect one to put a new one in, right? So things were getting shorter. They weren't even sure if they could do it. So when they decided to go ahead and list for their transplant, they knew that it would be the last one, right? They told the family very clearly, there won't be another one after this. So they waited for a very good match. And I remember sitting in ICU with her. I had sent mom home and just to go be with her kids for the afternoon. And we were about 2 days post transplant, and the one social worker came in, and he was like, "Well, did you hear?" And I was like, "Did I hear what?" Sometimes I'm like, "What is she on?" He's like, "Oh, we turned down 4 hearts before this one that she was a match to, and she was number 1 on the list, because they knew if it wasn't perfect, they weren't going to do it." And so, luckily she did fine, and she's 26, and her heart is still in perfect condition. So she actually just got cancer again, because transplant patients get cancer because they're immunosuppressed. So she's battling that. I think it's her 5th or 6th time. I've lost track. But she graduated from college. She was on her own. She's back with her parents while she's doing this cancer treatment. But she really is quite the miracle kiddo. But it all started with before she turned 2. So, all right. So it comes in 3 phases. The first phase is this super, super high fever. And the biggest thing is, you need to remember, is that strawberry tongue. Their tongue turns bright red. Can you want me to flip these off? Yeah. I know, these pictures are kind of hard to. Is that better, or is that better?
Oh, no. The second, yeah, that one.
Thank you.
That's
Okay. So, yeah, it's strawberry tongue, right? They get these big swollen lymph nodes, okay? And then they peel, they have this weird peeling, their tongue. No, they're around their fingernails and toes. So, the skin, right here around the edge. Yeah. It's kind of one of those zebra things, but when you see it, you're like, holy cow, right? And it's not a zebra enough that we talk about it, right? So just know that in this subacute phase, when that skin starts to peel, they have that joint pain, they're not acutely ill, but this is when they can have this clear aneurysm. And this convalescent phase can go on for quite some time. Where do I have my crash and burn? Okay, so this is what we talked about. The crash and burn is our diagnosis, mnemonic for it. So conjunctivitis, the rash, the lymph nodes, we've got adenopathy, that strawberry tongue, and swelling in the feet. And then the burn is that high fever that lasts more than 5 days. Okay, so remember that crash and burn. And we do give IVIG, okay, to these kids, and we do that aspirin therapy. I know we talk about no aspirin, and then today I'm guess what? We give aspirin. All that supportive care, okay? And these kiddos, even if they seem to come through, okay, we follow them really closely in pediatric cardiology, okay? Because we know there's some lasting implications there, even if they come through on that initial phase. All right? Question. Scary stuff, guys. Again, another really, really well done video. Goes in a little bit more like the patient became. It's probably more than you need to know, but I think it's good to know, you know? This is the one where like it'll be like your friend kid and you see it and you're like, you need to do something right? Even if you're not working on a pediatric unit. Okay, grab your case study worksheet. I want you guys to get with a partner and really quickly, it's going to take about maybe 5 minutes, so just a minute per case study. I want you to see if you can figure out based off the case study which cardiac condition the patient has. Okay. There's 5 of them. So see if you can write down why, what the basic nursing care is, and what the complications are. Okay? Do you guys have them? Do you have one? Or by who else needs a case study? Okay.
One more.
You guys will figure it out. We'll go through. Again, I'll give you just like 5 minutes. This is like quick recall. You can figure it out. Oh yeah, the 5 possibilities are right here. I know, I'm like, so the 5 we just talked about, so congestive heart failure, rheumatic fever, Kawasaki disease. Oh, I didn't do anything. Oh, well, just see if you can get them. We'll cover those in a minute. I think I put the slide in the wrong place. Yeah, that's okay. You guys are flexible and smart like that, right?
Well, now I'm stuck in this one. Yeah, because it feels like seeing that was on there, I was like, maybe it's something. No. Oh, we're going to do. Yeah. Strawberry.
Give a real tough to your little judgment. I put the slide in the wrong spot. Yeah. You got it? Okay. I know, right? We're just making sure you guys have all those homework sites done.
No.
You guys get one of these.
I grabbed one.
Okay. Check your phone. I thought you had 5. No, did you get ready?
We wrote that down already.
Oh.
Yes, I got that. Yeah, way too many left, but.
Okay, about 2 more minutes.
Were you talking?
No, I don't know. Either fluid or RLM.
But.
For
to reduce blood.
Yeah.
Right, looks like those bow tie questions. Can you figure out which? Oh, maybe I probably were talking about it.
Yeah, no, this is different.
Complication.
Yeah.
The first one was it's about reading that case already, right? And reaching out those symptoms no matter how. But you certainly need to really figure them out. Go to the market, cosmetic part. What are the main, that's the consultant can be for, what are the consultants? I want to say one slide.
What is it? AM?
Joint.
At least this one, yeah, that one, it comes with body. Body on, well, retaking it, I should have been
Yeah, there was only, all of the practice and drug and doing here, like 50 and 70.
So we've done things, there's 40, and then there's open, there's body, yeah, yep.
I think I got the.
You know, I just let my hair down.
And they were building gallows for those. Yeah.
But I mean, it was like definitely, I like doing it.
So there you go.
We're going to the arena.
Right, that's what we're trying to help you guys pull out.
I don't know.
Okay, all right, let's talk about it, okay? Remember, these things like these congenital heart defects or these, I don't know, these are like prime targets for those NCLEX butterfly questions, right? We're gonna give you a case study and you're gonna have to be like, okay, which little thing makes it this versus that, right? So, okay, case study 1, the pill preschooler. What do you guys think he has? Okay, what about that case study, what points in there made you think that it is correct? So what makes you think it's iron deficiency? So.
Vitals are all fun.
Okay, being a picky eater and having an excessive milk intake, we'll talk about that when we get to those slides, so is a huge risk factor for that as well.
So the calcium and iron.
No, it just has to do with like babies who love milk. That's all they end up with anemia, because they don't eat the solid foods they need, so they don't get the iron they need. Okay. So what do? What's our nursing care? What are our main things we're gonna do? Right? We've got those butterflies. We know why it's there. We've chosen that it's iron deficiency anemia. What are our nursing actions on the other side of that equation?
There's sulfate solution.
Okay, iron infusion, or well, not infusion, but like ferrous sulfate medication. Okay. What else did you say?
with orange.
So nutrition too. Yeah, and who just said OJ? Oh, see, you are so good. You've been dynamic cuisine, I can tell.
With orange juice.
Okay. All right. What about, do we monitor their growth?
Yeah.
Yeah,
Okay. Yeah. Do we look for delays?
absolutely.
Okay, so early intervention, right? Do we think there's a possibility of having learning difficulties with kids like that?
Yeah.
You could probably put that on all these. Okay. All right, number 2. What do you guys think number 2 is? Tallahassee. Hey, good. Why?
The strawberry pond,
Strawberry pond. What else?
swollen hands and feet.
Good, rash, a rash.
And the conjunctivitis.
Good. Okay, what about the fever?
Fever.
It could, but,
But with the rest of them, yes.
but it is, chief complaint is a high fever for the last 5 days and a rash.
Okay.
Okay, so that right there and the age, you should like start taking cowpox right away. Okay? So don't get lost in some of the other stuff when like you had your answer like online too.
Yeah.
Right? Okay. All right. What are we gonna do nursing care wise? What do we do for them?
Aspirin.
So yeah, potentially aspirin, high dose aspirin, IVIG, remember? Uh-huh. And then fever reduction, supportive care. Right? But cardiac monitoring, lots of follow-up appointments. Okay, they've got to be enrolled in pediatric cardiology clinic. Okay, what kind of complications could occur from cowpox?
You couldn't even.
Yeah. So coronary artery aneurysm, okay? They can have heart attacks, they can get heart failure. Okay, and it can come back, right? They can get it in the lungs. Be dormant for a while and come up. Okay, what about 3?
Rheumatic
Fever. Okay, why?
The murmur. Yeah, fever and joint pain.
A new murmur, yep. Okay, is our Jones criteria there? Okay, do we have joint pain?
Mm-hmm.
Do we have nodules?
I don't know.
No. Okay, you don't have to have them all, I'm just asking. Do we have a lacy rash?
Yeah.
Do we have symptoms Korea? No. Doesn't say that, does it? But we would be watching for it, right? Okay, what are we gonna do nursing care wise for this patient?
Action, fever.
Essentially, fever control. Do we encourage them to get up and move around?
No,
to get better?
bed rest.
Okay. Do we give them antibiotics?
Yes.
Prescribed. And they take prophylactic antibiotics before they do anything?
Yes.
Okay, complications are what?
More,
Okay, so rheumatic heart disease,
Yeah.
autoimmune.
okay, and then it can reoccur if they get suture direct infection. Okay,
So if it's treated like right away, it can. Okay.
and they can end up with some pretty funky arrhythmias too. Okay, case study 4. What does this patient have?
Sickle cell.
Sickle cell, and what are they describing here? What do we call this stage that they're in?
Crisis.
It's a crisis, we call it a vaso-occlusive crisis, right? So when the cells have sickled and then we can't get them, we'll talk about sickle cell in a little bit more depth. But essentially, right, hydration, pain management, oxygen therapy, avoiding the triggers. We'll talk about it when we get to that slide. Complications, mostly like chronic organ damage, right? If they're not oxygenated, then we can end up with organ damage of all sorts of kinds. Okay, let's do the last one and then we'll flip to those slides to talk about those more in depth. What's case study 5?
Just
Deja, yeah, what, how many you think that?
They're tired during feeding.
Yeah, exactly, not feeding, what else?
Yeah,
Rhythm.
Okay. Yeah, good job. What are we gonna do with nursing care wise? What kind of meds do we give? Diuretic, maybe, yeah, what else?
Weight, monitor weight.
Monitor their weight. What other meds do we give? Digoxin, yeah. Okay, and then, something I didn't mention, but we can use, you know how nipples come in different, sizes, like in different holes? How would we help this baby not expend so much energy when they ate? Would we use like bigger, more holes? Yeah, something that's easier to get milk out of, right? We just want to make it as easy as we can. We don't want them to use the extra calories. Okay? All right. Okay, let's keep moving on. Keep those case studies, you want to refer to those. When we get ready to go have full speed. Okay, really quick, let's look at iron deficiency anemia. So these kids are pale. Anyone ever had any babies in their families that are just white as some beautiful baby skin on the planet? Do we need help in message? Do we what? Do we need a pumpkin? Oh, yes. I will. I know, right? I'll go grab it. Anyone seen, we call them milk babies. Very lovingly, because they're just babies who love to breastfeed, and they just breastfeed and breastfeed and breastfeed, and they're 6, 7, 8 months old and just still breastfeeding like a newborn, and don't want to eat solid food because mom's just happy to breastfeed them, and they're these pudgy little cute white as a ghost face, and they have beautiful skin. They look like little porcelain dolls, but it's not really hungry. Okay, let's just finish this anemia and then we'll take a break. Okay, so they usually have poor dietary iron uptake. So one of the things that breast milk is really awesome for a million things, but we don't transfer iron very well. Okay, so with our breastfed babies, usually at a couple months old, the pediatrician is going to have mom start an iron supplement. Okay, and then we want her to start iron fortified cereal at what age? You guys remember? 1. Remember, one of the first things we feed, it's smooth, it's bland, they love it. What's it called? What do we feed babies on? Right? Yeah, right? Cereal. It's iron fortified. It's one of the first things we start them on. And what age do we start that at? 6 months. Yeah, like 4 to 6 months, we start adding that in, okay? But a lot of moms don't want to do that, but we need to remind them why.
It takes the bonding away.
Yeah, but because you don't have to stop breastfeeding just because you give them a little bit of rice cereal.
Oh, no, I'm all for all of it.
Oh, you're all for it.
Just saying.
Oh, okay. She's like, okay. What else do we need to talk about on that one? So we talked about treatment, right? Iron-rich foods for moms, so fortified cereals. If they're older, we can encourage beans, leafy greens, meat. Meat is always number one if it's appropriate for the age of the child. All right? And then, Destiny, tell us about this.
Yeah, that's because it helps it absorb more.
Yeah. So we could give it with a tiny bit of juice or something that has vitamins in it, okay? And then when babies get older, we need to limit their milk intake to 24 ounces a day so that they eat other foods. This is a really hard one for moms who are great milk producers and babies who love to breastfeed, because they would rather just drink milk all day and not eat other things. So we do say, you know what, it's time to cut back as they get older. We want to limit to 24. We're going to check the H&H, okay, and then we're going to talk to parents about side effects of the iron supplement, okay, and then encourage their compliance with getting those labs rechecked to make sure that they're okay. Most of the time, they'll poke your baby's finger or their big toe at about their 1 year, and we haven't suspected something before that, just to make sure their iron's good. So it's usually about that year, 9 months to a year of that checkup. Okay, hope there's our little kid. Okay, take a break. I'll go grab that for tea, and we'll resume when we talk about critical cells and biology. Okay.
No, I didn't have one. Yeah, unfortunately.
I think everybody is, right?
24 hours.
Oh, is that more? So a little bit heavy on P stuff today, because that CMS override. I know, I'm like, we gotta get through it. You can't just send you home to do it on your own because you're not home before you test. Okay.
Figure this out.
Change it up.
Okay, where? Is this one where we're all about?
Right?
Holy. Looking at my doorbell camera and we have so much snow.
Where
Oh my goodness.
do you live?
Payson, there is so much.
I need to ask my husband how much snow is up there.
The only thing I'm worried about is my kids going home and making my house a wet mess because they're gonna wanna go play in the snow.
I know, my kids are gonna want to play with something, and I'm going, no.
Mud everywhere, snow all over the carpet. I hate it. And then the
Take my
dogs,
dog out.
the dogs are gonna roll around in it and come back and get the house.
It's, you would think my one dog was a husky, the way he acts when it starts to snow. He's not, he's far from it.
Really?
Yeah.
That's hilarious.
It's a Staffordshire Terrier mixed with a Border Collie.
Okay. Yeah, you think he'd be out rolling around in it and all the things.
Oh, but he loves the snow, and I'm like, I can't move on to both at the same time.
I have one that won't leave the deck to go to the bathroom and I'm like,
Yeah.
you've gotta go, and then the other one's rolling around in it.
One put him on a sweater on him.
Get my boots, Mom.
They're spoiled. Do we have to put our student ID on these?
No, she can do it by your name. I've got an iron deficiency question. Avoid diet consisting of primarily milk. I think that's right.
Low and off with everyone getting level.
You what?
My workshop moving up because everyone's getting love awards. We're getting the awards.
Oh, did you get one?
No, I'm not that nice.
We,
But you do night, so you probably feel like night shift is underappreciated.
They really are though.
No, really, I'm not that nice.
which is why you're underappreciated.
You got that bed manner that everybody does.
I do not go above and beyond. Especially with my one patient, she was like, she got so mad because I wouldn't go get her another soda. I'm like, dude, you have 4 right there that you haven't even drank. You're crazy if you think I'm gonna go get you another one.
Probably just bored at that point, but yeah,
Oh,
I'm
she started
making you
calling
fun.
up every name in the book, and then she was like, will you go get me a soda? I'm like, no, I'm not going. I'm like, here's some water though. She's like, you effing EICTA, so I'm like, I know.
You're like, trust me.
I know.
She's like, you ain't saying nothing yet.
Well, I don't care about words, because I don't care.
When you see it on a night?
No.
Oh, yeah, just go on. Very simple. How warm is here? Compared outside? But they were in here.
And that's oh.
How was your minute?
Like, are you doing every morning? I'm like, I need to
Like,
take
what do you call it? Like,
Oh, well, you've been-
specified in my, that's why I'm taking it in my future.
I know.
What is, when you live there?
My future is Facebook, but I can't.
I thought that would have been one of those.
Like, think of like
Usually a mix. It's usually like a solution.
So you mix it with formula?
no.
It would be,
Because if you mix it with formula, then how much is the baby really getting of that medication?
yeah.
So we're gonna put the syringe to the side of their tongue.
Yeah.
Yeah.
For HIs, I think you want to sign up for the 15th and not the 14th, or is that?
Go this way. Sorry, do that person. I'm gonna go to Walmart, and I'm driving my big truck. I'll end up somehow, like, not intentionally making it so that way I have to go against traffic, like, you know how they have the arrows for the lanes? Or the,
Can you parking lot?
yeah.
Yeah.
Like, you can only go one way.
Oh, yeah.
I'll be that person where I'm going the opposite way, but no one else can come in because her butt's so big. So I'm just like, yeah, I'm that person right now. Sorry, guys. I hate the people when I do that. Like, I don't think about it. I just, yeah.
What is everyone bringing on Friday?
It's Friday.
Our post party.
I
Should I write it on the board? Yeah.
And I'll bring vinegar and
Oh,
water.
You're walking, pointed directly at me. How's the?
Cause I'm some things through what is it?
Yeah, you
I'll cut it.
Look at Charlotte,
Okay, friend.
but then when she started putting on Charlie, she was like, she should probably go with Erica. But I helped her a little bit. Back to Charlotte.
How are the CNAs?
They're good. They've hired some new ones.
Oh, really?
Yeah.
We should do it on Monday if you're not busy.
No, there was one new one.
Like, I think I can manage.
But she also just
As
saying,
long as I
just
don't
kind of
take
like,
another step afterwards.
sure, you are the ones that are there, so.
Well, the one chick out there was
The
like.
brown hair that was like,
So there's
helping
people
me
who-
get a child teacher.
Oh, really?
Yeah.
Why?
She's just like, kind of like quick and aggressive with the patients, I guess, just like
Oh.
turning over.
We can do that.
I don't know.
I'll send you.
We should find them down in the booth somewhere.
That's good. I think it's just like when she's on her
Um,
own.
After
And she was
class
on
or after.
whatever the whole Hamlin.
And
Yeah.
we'll go over,
Who?
time
The brown hair?
with me.
She did, she was there yesterday.
Yeah, no, I don't know when we're on.
Oh, she's already put it
Can you go over time? for
They-
me?
that's what she told me last
That
time.
I'm missing, like, 43 and
I'm not
3
reading.
seconds.
Hey,
And then
A lot of the-
my clinical results are there too.
Yeah, let's go over.
And
the- the-
Yeah.
the-
All right,
I
guys.
don't know her name.
So we've done some sickle cell, in Finn, if you remember back a ways. I think it was the end of last term, right? So tell me, who's at risk for sickle cell, what population?
African American.
African Americans, okay, and do they usually live in Utah? No. No. And how do they get it? It's double recessive, and what chromosome is it linked to? So it's X-linked. So what does that mean for boys?
my-
They're more prone-to Yeah, 'cause they only have one X chromosome, right? So for a girl to get it, both of her parents would have to be carriers. But where males only have the one X chromosome, right, the X-linked characteristics tend to play out a little bit more. So a lot of times they're male. That is because of that.
So what would, like, living in Utah have anything to do?
They can't. They can't oxygen here. I remember when they're oxygen, like when they get stressed, their cells tend to sickle. So stress brings on a sickling crisis.
Okay.
And so even if they visit here, they end up oftentimes in a,
But they.
So will they need like humidity? Is that?
they need like sea level.
Sea level.
Too high.
I would think even visiting here would make it
Yeah.
worse. Maybe if you're
Correct.
climatized.
Did live
maybe.
here, was that like life expectancy?
I had never met a sickle cell patient working here till I left the state and went to work at a sea level state. I saw my very first sickle cell patient more than 10 years into my career.
So
I
where,
kind of thought they were like a textbook anomaly until I left the state.
so would, cause like, is sickle cell, like signs of that when, they have like patches of white skin around? Or is that,
No, that's different.
I'm confusing them.
Yes, you are.
Okay.
So, okay, remember too, like our normal red blood cells live like 120 days, and a sickle cell has a life of, I think, around 20 days. Okay, so they have to kick out way more red blood cells. Okay? Plus, those sickle cells, they don't reaction well, and when they get into that vaso-occlusive crisis, remember, the cells should be like slippery and soft and pliable, right, to get through all the tiny capillary bones. But if they're sickled, they get stuck, and so they form like all these microclots, right? So they have extreme pain. So things like the capillaries in your skin and your organs and things like that, they're all suffering from lack of oxygen. That sickling occurs. Okay?
Their kidneys work like more than, cause they have to pump out like.
So what cleans out our red blood cells? Which organ cleans out our red blood cells?
Liver.
Spleen. So we end up with an enlarged. So you're right. You're thinking that one.
I think of it, so the kidneys, tell the liver to use that or.
So are you saying like we give them to stimulate red blood cell production?
I was thinking they have to like produce that more to stimulate.
I think I know where you're but I don't know the answer to your question. We'll have to look at that. But if we stimulated them to produce more red blood cells, we would just produce more red blood cells that can sickle. Okay, so what they end up getting are a lot of blood transfusions of non-sickle cells. Okay, so 20 years ago, what were they at risk for then? What did a lot of them have? HIV, because they had so many transfusions. Okay. All right.
Is that like back in the day? Because now they test it, right?
Well, is it 100%?
No.
Well, if you get enough blood transfusions, potentially, but our blood supply is astronomically safer than it used to be. Okay, our testing is really good, but it's probably not 100%. I don't know that anyone could say that it's 100%. But we didn't, I mean, it absolutely, we didn't have the testing 20 and 30 years ago that we have today, right? Okay, so triggers. Let me get to this next one. Okay. Oh, hang on, let me go back. Okay, triggers. Right here, dehydration. Okay, just being out in the sun at the heat can trigger crisis. Okay, infection. They get a cold. Okay, they get stressed. Probably nursing school not for them.
They can't be cold.
If they get cold or if they get hypoxic, okay, all those things can trigger a sickling crisis. One of my first patients I took care of that had this, and I was like, oh, this is the thing. Well, the mom who was delivering, and just the stress of labor and delivery caused her to go into a sickle crisis.
Yeah. That sounds like.
What were you doing?
Because, well, the stress of like pushing a baby out. Until then, I was like asking myself all these questions. Well, do we normally just C-section them then? Or like, no, the stress of the surgery is almost going to guarantee that too. So, like heavy epidurals, they try not to have them push very much, have them labor down. You know, they try to minimize
Do
that.
they have transfusion going during pregnancy?
Or do like a vac, right?
Not what?
Like one of those vacuums to take them out.
Oh, I can't even remember. She was in so much pain though. Like I
Yeah.
remember, thinking, wow, this really happened.
Interesting.
And the pain can happen anywhere that the sickles are happening.
Well, right, it happens everywhere,
Yeah.
right? Because your organs are all oxygen deprived, your skin, everything. Yeah. Okay, but we do give them lots of fluid, okay? So right here, hydration, at least a couple liters a day. All right, and they need to rest, we do lots of pain controls. The one thing I do remember is when baby we did have to do opiate withdrawal with her little one because they're in so much pain, you guys, I can't even tell you how much. And then we do give them hydroxyurea. It does tend to reduce the number of crises they have and the severity. What else can we use that drug for? You've seen that name before.
Mm-hmm.
Oh.
Mm-hmm.
Nice.
Good job.
There you go.
Let's see. In terms of non-pharmacological pain relief, what could you do for them?
Warm them up.
Yeah,
Remember yet.
warm pat. Mhm. Definitely. Sometimes just distraction, right? Okay, but look, high altitude, strenuous activity, and cold exposure are a no-go. That means no skiing in Utah. Okay, no, yeah, the patients are not gonna do that. All right, thalassemia, another inherited blood disorder. What do you guys know about this one?
Not a lot.
Inherited.
Perfect. Okay,
Abnormal hemoglobin.
so I want you to think about this one, in terms of, like, if our red blood cells are like little building blocks of hemoglobin, this is where they didn't like stack them properly to make the molecule right. Like there's an issue with the way they were assembled. This is an assembly line problem. Okay. So remember, I'm gonna look here because
So is it like we're sickle sick and these ones, they just don't form together?
yeah, so they're fragile, they break down, their globulin chains or globin chains are either reduced or absent. And so then the bone marrow works overtime to compensate, and then it can lead to bone deformities because our bones have to get so big.
So the,
Honestly don't ever recall speaking to a patient with it. That could be just the populations I've been exposed to, or I just didn't know, or it wasn't diagnosed yet. But
the hemoglobin that, attaches with oxygen,
well, I don't think it has to do with that, but what we have to do is give them a lot of vitamin Bs and then give them chelating agents to pull off the extra iron. Because we've given them so much blood that they'll be in like an iron overload.
Like they're.
Yeah. Yep. Interesting, huh?
Yeah.
so it's just, no,
So
no.
lifelong blood transfusions, and then both of these they're starting to do like stem cell transplants that are working. So I think there's new treatments on the horizon, like potentially to cure it.
Or sickle cell and thalassemia.
Yeah. So the key here, right, fragile red blood cells, chronic anemia, because it's defective, and then they are going to look very jaundiced because we're breaking down all those red blood cells, right? And just like when babies are jaundiced, it's because we're breaking down all the fetal hemoglobin. These guys end up looking very bronzed, or not quite jaundiced, it's more like a bronze, but they have a really funky. They would describe it as a bronze. Okay? Big spleen, same reason, right? And then heart failure that's severe. Okay, so for this one, frequent blood transfusions, that iron chelation therapy, because we gotta pull off the extra iron. And then potentially we take out their spleen, maybe a bone marrow transplant, okay? And honestly, chronic, when we see chronic, our hearts have to go out to them, right? These are possibly. Okay, last one, another inherited disorder, hemophilia. What do you guys know about this one?
Can't clock.
Yeah, the can't clot. The biggest thing you need to know, A is factor 8, and B is factor 9, also known as Christmas disease. But this factor 8 deficiency, hemophilia A, is the most common type, right? It's X-linked, again, carried by females typically, affects males more often. And when do you think we saw this one for the first time in a lot of our patients? People will be like, well, do you have any history of bleeding in your family? Nope. Well, there's only the first, right?
Mm-hmm.
So you two know we would start these little boys in the hospital.
With what?
When we would do their search, and they would bleed and bleed and bleed, and they'd be like, are you sure there's no bleeding? Yeah. Okay. Why do they call it Christmas? I have no idea. Probably somebody with the last name of Christmas. I guess.
Yeah.
So they can bleed into their joints, right? Okay? They can bleed anywhere, but obviously, no bleed, lots of bruising. These little ones, if they have hemophilia, they kind of like they've been beat up because just simple, I'm thinking you up can sometimes. Gums, cut, yeah. So also too, we do carry factor 8 and factor 9 at the hospital, but a lot of families now are taught to self-inject. We've got like they can give their kids the factor at home, or adults can give it to themselves. There's a lot of new technology, there are a lot of new, like, medical advancements. So, so factor replacement is the cure, it's not a cure, but it's a treatment, okay? And then we can use desmopressin for hemophilia A if it's a mild case. No platelet inhibitors, no blood thinners, right? Okay? If they have an active bleeding episode, okay, we don't want to be moving their joints. We're not going to be doing like range of motion with these patients. We're going to be letting them sit quiet. Yeah.
Would they also be more prone to getting like osteoporosis?
I don't feel the answer to that. Why are you thinking osteoporosis?
I'm just thinking because of like the bones and then the blood already. So if it would just start breaking down because they're already so brittle.
I don't think it's the
They're
bones
not
are
moving
brittle,
as
that's a
much?
different
Okay.
topic. Ice and pressure, okay? After that bleeding, the bleeding crisis is over, then really gentle range of motion to get those joints moving again, okay? And then these kids have to be prevented from like hurting themselves, okay? Like bad news if they, right? Like they're not gonna be out like learning how to ride a bike at age 2.5 or 3, you know? We're not sticking them on the four-wheeler. We're not, yeah, they have to be fairly protected. Which is kind of a bummer. Yeah, that's really hard.
NIH says they do get osteoporosis.
They do?
Increased
Okay.
risk.
There you go. I learned something new. Not can we go home?
Yeah.
All right, there are hemophilia foundations, okay, so we can make those referrals. Again, you know, immobilizing, so what kinds of things would you not tell this, what would you tell this mom she can't do with this kid?
Put them in sports.
Yeah, this kid's not playing football, right? Yeah. Okay. We need to tell the camp counselor, you can't just give this kid an ibuprofen. Right? These are the kinds of kids too where like, I think they have special camps and stuff for them.
To like socialize with other
Yeah.
kids.
Hey,
They've got to feel.
this is for you guys, we'll do it during the break, maybe.
Okay.
Okay, all right. Okay, let's talk about leukemia. What do you guys know about leukemia?
One blood flow. It's very sad. And it's the most common.
Except in childhood, it's pretty treatable. I mean, it's gonna be a rough go. I'm not saying it's gonna be an easy road.
My sister had it.
Okay. How old?
She got it when she was 17, and
Okay.
she's 40 now.
Okay, and has she had any reoccurrence? No. And how long is her treatment phase? You're
18 months,
older or younger than you?
older. She's 10 years older than me.
Okay, you're pretty little.
Yeah.
And how is her life different now?
Her and her husband were never able to have kids.
Okay, because of the chemotherapy.
But she said that she struggles with memory problems.
Okay.
She attributes it to the treatment, but she's not 100% sure.
They call it chemo burden for a reason.
Yeah.
Yeah.
So.
And you bring up a really interesting point. One of the treatments is I think if they're older than 12, they will try to do an egg retrieval before they start chemotherapy now with kids.
Oh.
So that they can potentially prevent their ability to have children. So we're thinking ahead, we're getting better at stuff like that, right? So the biggest thing here, so we have ALL, okay, it accounts for about 75%, much more treatable than AML, which is less common but has a much more lower prognosis rate, right? Poor prognosis. Biggest thing to remember is that when we are kicking out gobs and gobs and gobs of white blood cells, okay, we can't produce nether cells. We've crowded out the bone marrow. So what we're sometimes chasing is the fact that we're anemic because we don't have red blood cells and we have such low platelets that we need bleed. Okay? So what are we talking white blood count here? What numbers are we talking? What's normal?
5 to 10,000.
About that, sometimes 5, sometimes 8, depends on the lab. So what would an inspection look like?
Like
14,000.
14 to 25, 30, 35, you know, acute appendicitis, you're gonna be maybe up in the 30s. Okay, so what does leukemia look like?
a million.
200.
100?
Yeah, like 200,000.
Like a lot of times up in the 80s, 90s, 100s. Okay, so if you saw that on a question, you would be able to sort out the difference between, oh, maybe they're unhappy, or maybe this is so high that this looks like this is leukemia. Okay. All right. Again, pale, fever, joint pain, they, you know, a lot of times the first signs we see this are from like the lack of platelets, so we see that bleeding.
So my father-in-law had myelodysplastic syndrome, and his
I don't know what that is.
oh, I was gonna ask you, like his
Is that bad for me to admit? I'm like, you tell.
anyway, he just kept calling it pre-leukemia, and so, or his
I honestly don't know.
oncologist kept calling it
Do you
pre-leukemia.
remember how your sister presented? How did they figure it out?
She had several bruises that she couldn't explain.
Which is, that's a pretty common.
Do they like first thing before it's diagnosed, like maybe it's like some type of child abuse?
I think
Or
I've heard of that.
iron, or the first thing?
Because where would we go? Like, we're trained to think,
Yeah.
you know, we gotta rule that out too. But a simple CBC though would let us know the difference, right?
Yeah.
Yeah.
Okay. So think, low red blood cells, low platelets, and then that dysfunctional white blood cell count. So not only are there a lot of them, but they don't look right on the slide when we do that gram stain, we look at those cells, okay? All right, treatment, oh, go back. Treatment, okay, we have the induction phase, the consolidation phase, and maintenance. So remember chemo, we don't do the same amount of chemo the whole time, all right? And then bone marrow transplant if we need to. Mostly our nursing care is about managing all the side effects of the chemo and then making sure they don't get an infection on top of it, okay? And then all that emotional support. Yes, ma'am.
So it says cancer where the bone marrow fails to produce sufficient healthy red blood cells resulting in low blood count. Management primarily focuses on slowing disease progression into acute myeloid leukemia.
So it sounds like pre-leukemia to me.
Yeah.
I don't,
Yeah, like in between.
Sounds like
Yeah.
it's red blood
Yeah,
cells.
that
like
would be
it's white blood
and
cells.
there's lots of zebras out there, but remember, we're here to identify horses. And, you know, they have food
Special.
and 4 legs, and a tail, right? So make sure we know what the horses look like, and then we'll work on identifying the zebras on the road. Okay. But again, you know, they might have night sweats, easy bleeding, all that PTI, weakness, shortness of breath, okay? All right, so if we had to sort out the difference between sickle cell and hemophilia, here's your answer, okay? We have clotting problems from sickling, but here we have clotting factor, clotting problems, we don't have enough factor clot, right, in that cascade. Okay, we'll have pain crises over here, but on with hemophilia, we'll have those bleeding episodes. For sickle cell, hydration is critical, okay? The critical component of our nursing care. But the critical component over on hemophilia is getting the factor. We've got to infuse that factor back into order to the injection. And then for sickle cell, we've got to avoid hypoxia. Okay, that's one of the biggest triggers. And then for hemophilia, it's about avoiding trauma.
For the hydration, it's just so that way they don't sickle.
It also helps them, think about it, if it's thinner, if blood is thinner, it's going to move better through those smaller vessels. So it will help us prevent such severe vaso-occlusive crisis. Okay, is that, yep, that's the way I see it in my mind, right? Okay, so what's gonna kill the child first? If we have CHF, what is it?
Respiratory arrest.
Okay, if we have Kawasaki,
Coronary
aneurysm.
okay, sickle cell, leukemia, and hemophilia. Okay, so I'm gonna ask you again, what's gonna kill the kid with CHF first? Okay, what about hemophilia, bleeding.
Bleeding.
Okay, what about Kawasaki?
Aneurysm.
Okay, what about leukemia?
Infection.
What about hemophilia?
Trauma.
Bleeding. What about CHF?
Respiratory.
What about sickle cell?
No.
Sickle cell?
G and Utah.
Hypoxia or having a stroke.
Okay.
Okay, leukemia, hemophilia,
Bleeding.
CHF,
Respiratory.
sickle cell. Infection. Okay, you got those words connected? They're in there somewhere. Okay.
There's gonna be a bunch of numbers.
Really? So if you guys will take the other topics that you are struggling with, if you have seen things come back on your testing over and over and over again, I know you have, I know what they are. And figure these out, and if you can just come up with the 2 words that are connected and get that down, you have done 80 to 90% of the recall, right? The rest hopefully will come to you, but I'm hoping that if you really read your questions well, and you can create yourself some tables like this, or like have Claire maybe help you whittle it down to this, or something that you can have better recall on these exams. Okay, I think you're trying to look at like the whole jungle, and I really just need you to look at like the plant right in front of you. Does that make sense? I don't know, I don't know what else to do to help you guys have better recall when it comes to the exams, but you're missing like some of the key words that are right there in the question, because you're looking for things that aren't there, right? You're looking for this big picture, and they're giving you one key risk factor, okay? So really, if you know what the big ones are, I mean, it's gonna get you 80% there, right? Okay. All right, so red flags, okay? So the red flag for CHF, okay, increased respiratory rate, or they're sweating while they're feeding, not feeding well. Kawasaki's chest pain, tachycardia, sickle cell, a high fever, okay, 101 plus, hemophilia, head injury, right? And leukemia is going to be that leukemia, which is a little like what that once they've like exhausted everything, and then okay. So this is when we're going to call the doctor. You know, this is what we tell parents, you got to bring them in it, okay? Because there's always that component with our pediatrics.
5 days ago.
What's that? You needed this 5 days ago?
Oh,
Oh, no, I was looking up what neutropenia meant, and I Googled the word 5 days ago too, and I'm doing it again. It doesn't stick.
Okay, so, yeah, red flags, okay? So know exactly what the risk factors are, and know what those red flags are.
And there's no new.
Okay, we're gonna come back, we'll play this Jeopardy game, in the break. Whoever wants to stay and drill some of these in before we go, we'll do that.
Okay.
But we're gonna spend just a few minutes on death and dying. Yeah.
Before we do that one, can you go over some of the words we were talking about yesterday that, you were saying, like, the distractor words?
Yeah.
That would be great.
We could.
I'm gonna put it to the test on the test.
You're gonna put it to the test on the test. Okay, so what I will tell you that in the 90s, like I have pretty well dressed it, not just day dress, but I have a section in my wardrobe that was just
That's cute.
That's the baby box. You know, we tried really hard, but we just didn't have some of the advancements on our side that we have now. Nowadays, I was chatting with a couple of the gals in the NICU, actually last weekend when I picked up stuff. And I was asking them, I'm like, so, like, have you ever lost baby in the NICU? You know, like, oh, I've been here like this long and done to that, and you know, and the answer was no. Like, they've been working in the NICU for years and haven't had a baby die. So that just tells you how much further we've come. I will tell you a good portion of those were lost to GBS stuff, right? But now we have protocols that you're going to have companies, moms will expect to do that, which is why I get so crazy when moms are like, I don't want antibiotics, they're poison, and I'm like, so clearly she didn't live in the 90s when we had so many. So because of that, right, it's probably in 94, maybe 95, there was kind of a coalition of nurses who got together and we met back in Cincinnati and decided that it was kind of time to have like official bereavement nurses in the NICU and the PICU. Because we decided that death and dying should be different if it was kids. And so I spent a week that year back in Cincinnati where we got together. They brought in, some experts. They brought in like some parent panels, and we started to put together like our first sort of like national training and certification. And then we continued to meet and bring things back all across the U.S. to our facilities. And then we hosted our first bereavement conference. I hosted the first two in 98 and 99, where we were then training our own nurses here in the Valley. And so, but it's really important to understand when we're talking about pediatric death and dying that it is all based on the developmental stage, okay? So whether that is the developmental stage potentially of the parent who might be 12 or 14, who just had a stillbirth, or whether that's a 2-year-old who's passing away, or whether that's a 10-year-old or a 15-year-old, right? Everything we do is based on the developmental stage of either the parent or the child themselves. I can't stress enough how important it is to be honest. We tend, as medical professionals, like steer away from things that are uncomfortable to us. But like we do that in these types of scenarios, it's not really great. We really need to be compassionate, but we need to be honest. And if we also have to accept that we really go back and we rely really heavily on Erickson's stages, okay? Because we have to let them know in words that they can understand and that they can comprehend what's happening to them and or their siblings, right? This is the time where we take care of the whole family. We no longer just have one patient, right? And so what do you think it looks like to a 6-year-old if their older brother, who's 10, is dying and last week he said, I hate you. I wish you would die.
Yeah.
The 6-year-old thinks it's their fault, right? They're still in this magical thinking, like, I made that happen. Okay? What does it look like to a teenager? What does it look like to a 13-year-old who realizes they're not going to make it?
I don't even know.
Right? Is it the same as if you have an 8-year-old? No, it looks totally different. And it really depends on that child's life experiences to that point, okay? Like a 2-year-old may not perceive in words that we can understand that they are dying, but I will tell you they absolutely know they do. As does even a neonate, like they absolutely know. There's no question in my mind about that. But we still have to like acknowledge, like, what's the scariest thing for a 2-year-old? The monster, separation from mom, right? So if, we need to, address these issues based on the developmental level. So this one definitely goes back to Erickson stages, okay? Remember that we're family-centered and really our goals, it's about dignity, it's about helping them connect. We used to take even stillborns or even babies who only lived for a little bit and we just whisk them away. For some reason, we had it in our minds that it was better if parents didn't see them. We couldn't have been more wrong, right? And so this whole tidal wave of new thinking came about, and now we do all sorts of things with these babies, right? We make sure that we've collected hair and footprints, and we've taken pictures, and we know we have a limited time with them, and so we do as much as we can. It's not uncommon in the NICU setting, if we know we're withdrawing support, we'll have the whole family, so we actually have special rooms in the NICU where we can hook up all the life-saving equipment. We move everything off the unit to a special place where moms and dads can be there with their family in a more normal setting, right? It looks more like a living room setting. And they can spend time. And sometimes that's days. It's whatever they need. It may be hours and they're ready. It could be days. I mean, I've spent days in these family rooms waiting for them to be ready to withdraw support. And ask me about like tucking a baby into bed. You know, we have king size beds, you know, where parents can sleep in a normal thing. Yeah, tucking a vented baby into bed with mom and dad. And right at that point, we're just trying to give them whatever we can. And so we're pretty creative at making that happen. But the same is true for every age, whether you're in the PICU or, you know, the NICU, where you've heard of like Make-A-Wish or, right? Like we go to pretty exorbitant lengths to grant wishes and desires and to make whatever we can matter. Now, when I crossed over to adult nursing, I was like, you guys are really good at that. Like I went from this, like, we're here to grant every last wish you've ever had to nothing I can do. I'm like, whoa, like there's some of these principles that should have dropped. I'm like, we could make this a happier. I don't know. I feel like the rest of the nursing population, medical population could learn something from our pediatric population where, and I know it's just because we feel like it's too soon versus, oh, they lived their life, but I'm going to just say, I think we could take a little page out of that book and make those other experiences a little bit nicer.
For sure.
I don't know. My heart definitely lies with pediatrics on this aspect. I put in this video. She's a palliative care nurse practitioner, and yeah, get out your tissues. We're not going to watch it right now, but she talks about what it means to die with dignity and the things that we can do for our pediatric population. Pretty good. So we do have to address the types of grief though, and you will see, I actually think there's a good chance these will show up both on your CMSs and in your NCLEX. This is not specific to pediatrics, okay? But I thought this was a good to review it. So if we have anticipatory grief, like that's the mom crying because she knows they're going to come back to the hospital tomorrow and we're going to withdraw support, right? She's anticipating the grief of her child being gone. Even have you seen people grieve just about the decision to put their loved one on hospice? Okay, so that's anticipatory. Complicated is where they just can't function. And when people lose a baby, like this can happen for months. Okay, it just means it's just not, I like the word maladaptive. Okay, I don't know what normal really looks like. I don't want to put people into a box. But this is clearly outside of whatever that should be, okay? Parental grief is just the deep loss that parents experience. It is different. You know, you'll hear people say the worst thing they ever did was bury their child at whatever age that happened. And I think parents universally agree that that is the worst thing they've ever done. So parental grief has its own name. Sibling grief, okay, we oftentimes like forget about them. Parents forget about them. They are so caught up in their own grief and potentially the medical crisis that's occurred that the siblings are sometimes left to the dust. And then dysfunctional grief, so this is different than this complicated, okay? Because dysfunctional means like they're not grieving, they're displaying a whole other set of behaviors. Okay, so differentiate those. This, I mean, I can tell you, like, we love family stories, right? I have a sister-in-law, they lost a baby. Oh gosh, it was so dysfunctional. But to this day, okay, this has now been like more than 25 years. I want to say maybe 26 or 27 years since she lost this baby. She still has her other children carry his Easter basket and collect eggs for him every Easter. What do you think about that? I'm like, he doesn't need an Easter basket anymore. Like, we should have moved beyond. I can see, you know, he's still, his crib is still up in his room. And it's been, like, I'm thinking we're pushing for decades.
Holy cow.
Okay? That's dysfunctional grief. Okay? Complicated grief is just this, like, for 6 months, I didn't, like, all of a sudden I got, like, this notification that they're going to foreclose on my house because nobody pays the bills. Because nobody could like function well enough to like remember that we had to pay bills or we got in the car or something like that. That's different than I am like totally not in the summer with this, like I'm in the, okay? You kind of figured that out in your mind, if you read a scenario, how those differ. Okay. Questions on grief. There's no right way, guys. I've seen all kinds, but. Okay, 3 settings that you need to be aware of, right? We have hospice care. It's just like hospice for adults, okay? I think it's a little bit harder to say we're done with our pediatric population. There was a gal we had a couple years ago, when I was doing a lot of case management work. And she, I kid you not, like we had done more to this kiddo and she was like 14, but her mom was like not giving up. And I just thought to myself, like, at what point do you say enough is enough, right? Like I don't know. We had even flown her. I think just to help the mom maybe start to cope, like we put her on a medical jet with a full life like team and flew her to California for the special test. And because, you know, there was this one chance that maybe this, you know, and it just kept going and going and going. And I thought to myself, this is like it just became very burdensome to the nurses to just continue to care for her. Like the family was not ready. And honestly, she was so out of it, like it was hard to get her read. Because sometimes the child can decide, and they do. But anyway, hospice. But remember that we're focusing on dignity and we take away the pain. And a lot of times it's when they go on hospice, it's the first time that they spent a long period of time at home. They might have lived for a long time, mostly in the hospital. And so we transition to hospice care and we suddenly say, okay, you can, you know, go have a weeks or months like living a more normal life before you pass, because we're not going to do all these heroic things anymore. Home care, again, and hospice doesn't have to be at home, right? It can be in the hospital. Some parents aren't comfortable taking them home even when they're done doing the heroic. We try to get kids home. Parents usually want them home. Siblings usually feel very left out because they've been in the hospital, so we can get them home. And moms are okay with that. But sometimes they say, I don't want that memory. Like, I don't want them to die at home. Everybody has their own opinion, and that's okay. And then a lot of times, of course, they are in hospitals, and sometimes that's the best place, right? They need the support that we have there for them. Okay. We kind of break all the rules. We throw the rules out the window when kids are dying, right? You know, we have a grieving policy. We're just like, you know, but it causes problems. Like, inevitably, some other mom is like, I'm like, you know, and I don't want to just say to this other mom, well, their kid's dying. Can you just like be quiet and go back to your room and keep complaining that they had an extra visitor today? You know, it can cause issues for us in the hospital, which is why we can remove them from the normal like form bustle of a unit where they're more visible. We will, because it does make it easier for all of us. Okay, really quick. So we talked about developmental stages. So toddlers, I want you to think about separation. Okay. And they don't do well to change the routine. So even though they're dying, like we'll maintain routine because it keeps the child feeling comfortable and calm. All right. Even if it's things you have, it's what they need to just be calm and be comfortable. Those preschoolers, magical thinking. How often do you say, "Oh, grandma's asleep"? Yeah, not great. I love doing that one because we do that a lot in our society, right? And so then guess what? 5-year-olds who've been talked to about the chance, I mean, if they're starting to understand that they might die, do you think they ever want to go to sleep? No, because we say that way too much, okay? So we have to be careful, and we really, really, really want to avoid these kids associating death. That's actually a nightmare. School age, they honestly, they really think death is a bad thing for some reason. I don't know. They're kind of at a hard age to really wrap their head around it not being bad or not like thinking that somebody's going to come to them in the night or I don't know. So again, they need to know they didn't cause it. They're not responsible for it. They often feel like they're responsible for their mom and dad's sadness because they've seen mom and dad hurt and they pick up on that. And then adolescents are just what they say they actually are in denial, usually. Because they're invisible, right? And that carries through. So we do try to let them make decisions. I know when this friend of ours, when Lauren was going into the car transplant, she called me. I remember it was right after Thanksgiving. And did you know, like, transplants, they always have on, like, holiday weekends, right? In big cities, that's usually when organs become available to things. And so I get this call at like 3 o'clock in the morning, and she's like, do you want to go to the hospital with us? And then, like, well, like, yes, but, like, are we leaving, right? Like, I was trying to just get the lay of the land, you know, when you get notified, like, sometimes it's not immediate. It depends on the organ coming from. The organ was actually right there. So it's about 3 o'clock in the morning, and we had a really hard conversation before she went into surgery about what do you want to do if it doesn't go well. She's like, it's going to be fine. And I'm like, did you not hear everything the doctors have told you for the last 6 months? Like, there's a really high chance this isn't going to go well. And as her parents who fully understood, like, they're saying goodbye, sending her off to surgery, knowing there's a really good chance she's not coming back out of surgery. Total denial. Complete and total denial. So they're still teenagers, you know, and somehow we have to work with them on that level. So anyhow, peer support if it exists, but sometimes they really are in a land all their own, right?
I don't think it's easier to, like, ask them, they're like, oh, no, this just happened.
But I know does denial make it easier? Maybe. I get where you're coming from, Maggie. I really do.
Like,
I mean, for them, maybe, but maybe not for their loved ones,
yeah.
right? Because maybe they don't even want to do that Make-A-Wish trip because it's not happening to them. Right? I don't know. We've seen a lot. Okay. So if you had to, I don't know why that is showing up there, but okay. So infant, think separation, toddler, everything is reversible, preschool natural thinking, school age, they're just beginning that permanence, right? They just don't have it yet. And then adolescents, they should be understanding it on an adult level, but they're still adolescents. Okay, so what do we do? Simple, honest language, and really, I don't know is an okay answer, right? Because we don't. I will say, I didn't put this up here, but if for some reason you don't know what their religious background is, this is where having a really good understanding of different types of religion, because, you know, you can be in the PICU and I could have kids, you know, there could be 8 different religions, you know, and so, yeah. So, but it's pretty safe. You're almost always safe that most people believe in a life after death. Like, there's some like real basic concepts that you can be pretty safe with if you're not sure. Higher powers, those types of things. But for sure, we've got to, like, none of this, like, grandma went away, grandma went to sleep. Then, yeah, we got to really clean that up in our language. So that's my public service.
What about the you're in a better place now?
No, you don't say that.
Same goes for pets.
Yeah. And really, it's got to be simple. We do a lot of play, right? Lots of our childlike specialists are vital. You know, they really help kids through play and art and all those things to understand what's going on. Support the family, whatever that means. We can see a lot of variations of that. And then we already talked about regression. So this is right out of your textbook. Again, it's okay to say dead, death, dying. Like, we tend to steer away from those words in our society for some reason. We don't tell somebody you're dying. Like, I don't know, but it's really okay. We've got to be comfortable with that. Okay, we're not going to do this. You guys, I'll send it to you in an announcement, okay? But I want you to think about it, about how this impacts you and what is it. Okay, your discussion post, don't forget after your test, you still have a discussion post due tonight. Don't lose points on the very last one. And that is it. Okay, we are technically done with class. The question is, what do you guys, we have a half an hour till we test. I want everybody to take care of their physical and emotional needs, but I am willing to do a review, answer questions, whatever. I'm yours for 30 minutes before we go test. So you guys let me know what you need and want. I'm gonna just stop this and then.
The normal vital signs from like